I believe I allowed that. There we go.
There we go. Perfect. Thank you so much.
All right. Well, I'll leave you to it. I'm going to leave the meeting. So your co-host, so you should be good to go.
Great. Thank you so much.
All right. Thanks. And just a little reminder, your next one is on November 20th. I'll email you.
Perfect.
All right. Have a great day. Thanks.
Thanks. All right. Hi, everyone. So I assume you can see my screen that says head and neck pathology.
Yes.
Excellent. So I see that there are a number of you on here. Have any of you seen any of my lectures last year, or is this new to all of you guys?
I did, because I'm doing an off cycle. So I have attended some of the lectures from March to July.
Got it. Okay. Okay. So since this is the beginning of essentially a new academic year, I'm going to start sort of from the top. And so the way that the block of my lectures is going to go is we're going to start off today with some general basic concepts on pathology processing. And we're going to then go through the subsites of the head and neck, not necessarily in this particular order, but we're going to try to cover most of them throughout the duration of the 4 lectures that I'm going to be giving. So we'll start with just how we obtain tissue, and please feel free to type things in chat or ask questions if anything comes along during this next, 50 minutes ish. All right. So of course, for surgical pathology, so I'm a surgical pathologist. My subspecialties are head and neck and bone and soft tissue. So I work very closely with, otolaryngology, with orthopedic surgery, of course, with you guys during tumor boards, et cetera. And so we receive tissue either from biopsy or surgical removal. We perform a gross examination. We perform, of course, a microscopic examination, and we may perform any additional special studies on tissue, such as immunohistochemistry, molecular diagnostics, et cetera. We render a diagnosis to the medical record. And hopefully this diagnosis will impact treatment for the patient. So on gross examination, we essentially perform serial cross sections through larger specimens. So in this case, for example, a thyroid, you could see the right lobe, the isthmus, the left lobe is enlarged. When we do those serial cross sections, we see that in this case, there's tumor in the middle, which is white, flanked by normal kind of reddish thyroid on the top and bottom. Because these sections are generally too large to be processed, we have to take smaller sections for histologic examination. So how does that tissue get turned into a glass slide? So sections about the size of a nickel are placed into these plastic cassettes. These plastic cassettes are processed in a number of fixatives, and then the tissue itself is embedded in paraffin wax. And the reason for that is so that it could be cut on a microtome at about 3 to 5 microns thick, placed on a glass slide and stained. And so it's those stained slides that we use as the crux of our diagnosis. Just for your comparison, a red blood cell is about 7 microns. So the thickness of these slices is even thinner than a red blood cell. The stain that all cases get is standard hematoxylin and eosin. Hematoxylin is a basic or an alkaline dye. So it binds acids in the tissue, specifically nucleic acids, and it turns that tissue kind of bluish. So we call this blue or basophilic because it has an affinity, has an affinity towards the basic dye, essentially. Eosin is an acidic dye. So that generally binds the bases in the tissue, which is more located in the cytoplasm, the proteins, et cetera. So the tissue that binds eosin is called acidophilic because it has an affinity for the acid dye, or eosinophilic. So nuclei tend to be blue or basophilic. Cytoplasm tends to be pink or eosinophilic, as reflected in this image. Additional stains we can use are immunohistochemical, which detect specific proteins in the cytoplasm or nucleus. And so these, of course, are antibodies that are conjugated to dye. Usually the dye is either brown or red, mostly, as I'm going to be showing you here, brown dye with a blue background counterstain that just stains all of the tissue so we can sort of see what we're looking at. So in this case, the antibody is binding in the cytoplasm. So we see a cytoplasmic reaction and the nucleus is empty. And on the right, we see the antibody is binding a protein in the nucleus. So we have a nuclear reaction, and the cytoplasm and the cell membrane are essentially not staining. So this is very helpful to classify site of origin for tumors, identify specific proteins that are expressed in tissue. There are other stains that are less specific called histochemical, right? So these bind various types of chemicals or biologic structures, not necessarily specific proteins. For example, GMS, silver stain binds carbohydrates, all carbohydrates, any carbohydrates in fungal cell walls. So here, black with a green counter stain. Congo red binds amyloid, any kind of amyloid protein, whether it be, calcitonin in medullary carcinoma, whether it be kappa lambda light chains. So Congo red here, see binds the amyloids red, and there's a blue counter stain. And then, for example, mucin binds all your mucopolysaccharides, your mucin's red with a yellow counter stain. So because a lot of head and neck pathology is neoplastic, we're going to be talking just briefly about the nomenclature of tumors. And so when we think about mass-forming lesions in the body, certainly not all mass-forming lesions are neoplasms, right? You can have mass-like inflammations, fibroses, scars. You could have hyperplasias, and you can, of course, have neoplasias. Neoplasms are classified as clonal proliferations or originating from a single stem cell. And just to remind you, a neoplasia is an abnormal growth of tissue derived from a single progenitor stem cell, usually, as I said, a tissue stem cell rather than a mature differentiated adult cell. This stem cell has acquired a growth advantage due to some genetic or epigenetic changes, proliferates independent of normal signals. Of course, that's different from hyperplasia, which is polyclonal, meaning multiple cells grow up together in response to some kind of physiologic signal. Of course, within neoplasms, we have malignant neoplasms or cancers, basically with the potential to cause significant morbidity or mortality, as I'm sure you all know. So benign and malignant neoplasms are named according to their presumed tissue of origin or sort of histologic appearance. So tumors of epithelial tissues, if they're benign or adenomas, if they're malignant or carcinomas. Tumors of mesenchymal tissue, if they're malignant are called sarcomas. If they're benign, the name changes depending on what benign entity they recapitulate, fibroma, chondroma, etc. There are really no significant benign neoplasms of lymphoid organs, but the malignant ones are, of course, either lymphomas as occur in solid organs or leukemias as occur disseminated intravascularly. Tumors of melanocytes are either nevi or melanomas. And then you can certainly have tumors composed of various histologic types. So for example, adenofibroma is a tumor composed of both epithelial and mesenchymal tissues that are benign versus carcinosarcoma malignant. Okay, so moving on. Then within the carcinomas, these tumors are derived based on the epithelium they either resemble or are derived from. So squamous cell carcinoma generally resembles and in fact is derived from squamous epithelium. Adenocarcinoma resembles and is derived from glandular epithelium. It could be salivary gland, it could be prostate gland, it could be breast gland, it could be, pancreas gland. So any of these are considered adenocarcinomas. Conversely, sarcomas are named depending on the type of mesenchymal tissue they resemble. So for example, not all angiosarcomas necessarily are derived from vessels, but they resemble or recapitulate vessels, therefore they're called angiosarcomas. Same with here, cartilage, chondrosarcoma resembles cartilage and is therefore called chondrosarcoma. So a few terminologic words that we're going to be using throughout the course of these lectures, just how do we describe tumors? So we're going to start kind of from the outside in. So we tend to describe the outside of the tumor's border as being either well circumscribed or invasive, infiltrative, poorly circumscribed, which may imply a lower grade behavior versus a higher grade behavior, not necessarily, not strictly, but generally circumscription can be a good sign of behavior. Cellularity can be either hypo or hyper, so very few nuclei with lots of collagenous stroma versus many, many nuclei packed together. Growth pattern can be nested or corded or trabecular. Anything that has a structure to it implies some kind of cohesion between the cells, which generally implies they are of epithelial origin, because we know epithelial cells have cellular connections. This is in contrast to sheet-like growth pattern or some kind of growth pattern that does not form structures. This might imply something lymphoid or mesenchymal, where intercellular connections are not made, or are fewer and farther between. The morphology of the individual cells, we generally describe as epithelioid, meaning kind of abundant cytoplasm, open, oval, polygonal nuclei. This either looks like it could be epithelial in origin, or in fact is epithelial in origin. When we say something is spindled, that means it has elongated nuclei, kind of compressed. This usually implies something mesenchymal in origin. But if you think about it, anything that is of a mesenchymal stem cell origin can transdifferentiate to look epithelioid, and something that is of true epithelial origin can also sort of differentiate to look spindled or mesenchymoid in origin. So again, these morphologies are not necessarily strict, but they can generally be used to describe what the cells look like. Okay, tumor differentiation. So we tend to describe tumors as being either well differentiated or poorly differentiated, simply meaning do they resemble or not resemble their normal counterpart. So you may be able to tell on the left that this tissue is thyroid. So this is a well-differentiated thyroid lesion. It resembles normal thyroid tissue. On the right is a poorly differentiated thyroid lesion. If you looked at this, you would not be able to tell this is thyroid, right? But both in fact are thyroid. One is well-differentiated, one is poorly differentiated, or in fact undifferentiated. The one on the right is actually anaplastic thyroid carcinoma. Again, this implies better or worse biologic behavior. Additional features that we might use to suggest biologic behavior include things like nuclear pleomorphism or anaplasia. This means how similar are the nuclei to each other? Are they small and large? Are they round and oval and misshapen? Are they dark or hyperchromatic? We might look for mitoses, which imply rapid growth. We might look for necrosis, as seen here with grungy eosinophilic material with loss of nuclear detail. This implies that the tumor is growing so rapidly that it outgrows its blood supply and dies. Another word on mitoses, mitoses can go through that normal, prophase, metaphase, anaphase, telophase that we all learn about, in grade school, but those normal morphologic mitotic figures can be found in benign tissue, in hyperplastic tissue, and in malignant lesions. However, once a mitosis is morphologically abnormal, like tripolar or tetrapolar, that implies abnormal DNA, and that essentially implies malignancy. So just a comment on the morphology of mitoses. Just remember your pathologic features tend to describe something that might be benign or low-grade malignancy versus something that might be, malignant or high-grade malignancy. But none of these histologic features is necessarily 100%. So the presence of a single malignant feature doesn't automatically mean malignant behavior. All of them have to be taken into consideration when we are diagnosing and describing neoplasms, but they tend to cluster on one side or the other. Okay. Any questions on that sort of general path stuff before we move into the different subsites? If not, we will start in the oral cavity, because that's probably one of the more common sites we see diseases. So normal squamous epithelium, the oral cavity, is stratified squamous, right? So multiple layers. It usually has a distinct basal layer with maturation to the surface, meaning as the cell matures, it acquires increasing amounts of cytoplasmic keratin. So the nucleus becomes relatively smaller, the cytoplasm becomes relatively larger as it's filled with this protective keratin. One of the diseases that we see coming from the oral cavity is a autoimmune mucositis called lichen planus, usually of adult females. So clinically, it's these white streaks on top of red patches. A lot of the surface diseases we're going to see in the oral cavity are some kind of either discoloration, whether it be white or red of the oral cavity, or thickening of the mucosa, some sort of I guess, geographic, architectural, or coloring abnormality. So these are kind of the things we want to look for, right? But most of them require biopsy, not most, not all, most or many of them require biopsy for definitive diagnosis of, autoimmune disease, hyperplasia, dysplasia, carcinoma, et cetera. So in this case, our biopsy shows an epithelium that is somewhat thickened with these downward pointing so-called sawtooth reedy ridges and chronic inflammation in the superficial stroma. When the suspicion for lichen planus occurs, we ask the clinicians to send us a biopsy for immunofluorescence because we can see deposits of fibrinogen at the basement membrane here, which is in conjunction with the H&E morphology is quite good for lichen planus. Other vesiculobullous diseases that we might want immunofluorescence for are things like pemphigus vulgaris or bullous pemphigoid. So depending on where the blister originates, either within the epithelium, so intraepithelial or suprabasal, meaning above the basal layer, or subbasal, subepithelial, below the basal layer, these are two different diagnoses. The intraepithelial blisters happen in pemphigus vulgaris, the subbasal in bullous pemphigoid, and we see differential deposition on immunofluorescence. The desmosomes are the ones that are affected in pemphigus vulgaris. So you see this kind of meshwork or this fishnet structure within the desmosomes compared to, again, this basement membrane deposition in pemphigoid. So when a biopsy is desired for immunofluorescence, we ask biopsies to be sort of taken at the edge of the lesion so that there is an interface between the lesion and the normal. One biopsy be taken for routine H&E processing and formalin, and one for immunofluorescence in a fixative that is sometimes called either Zeus's or Michelle's. These are specific for processing tissue for immunofluorescence studies. Okay, moving into our deeper epithelial, subepithelial lesions of tongue. So two more common lesions that we see either in children or adults are lesions composed of histologically granular cells. And so I put these two together because of their histologic similarity. Granular cell tumor is a usually sessile or deep tumor of adults, can be located on the tongue, the larynx, even in the skin. It's composed of these granular cells with indistinct cell borders, and they, in fact, are positive for markers of Schwann cell differentiation, such as S100 or SOX10, so they're thought to be modified Schwann cells. Conversely, epulus is a tumor of newborns present on the alveolar ridge. So you can see this exophytic kind of pedunculated mass. These are not considered modified Schwann cells. They are not expressing your Schwann cell markers. And then the words I said here, pseudoepitheliomatous hyperplasia, what does that mean? Well, the epithelium overlying a granular cell tumor tends to be quite extensive, proliferative, and hyperplastic. That over an epulus is not. So two kind of interesting subepithelial tumors, either in children or adults. One other common subepithelial tumor we see is pyogenic granuloma, which is kind of synonymous with lobular capillary hemangioma. I prefer lobular capillary hemangioma because that tells you more closely what it is. It is a lobulated proliferation of small capillaries forming overall a vascular lesion, i.e. a hemangioma. So in this case, you can see these multiple lobules in the stroma. On higher power, you can see that they're composed of these slit-like capillary spaces, sometimes with mitotic figures. That's okay. These can be rapidly growing, but the mitoses should be morphologically normal. So this is a lobular capillary hemangioma. Other surface lesions that we might see that are related to infection are hyperplastic candidiasis. So hyperplastic candidiasis is a fungal disease that essentially isn't wiped off just like thrush, right? So you see these white plaques on the person's tongue and they cannot be wiped off. The differential diagnosis clinically might be something like dysplasia, hyperplasia, infection. So generally these are biopsied. The epithelium looks very thick or hyperplastic with these very bulbous reedy. If you look carefully, you see neutrophils in the superficial epithelium, But most specifically, you see these yeast forms, these pseudohyphae, piercing through the keratinocytes in the superficial epithelial layers. So this triad of hyperplasia, neutrophils, and punctuating yeast forms is specific for hyperplastic candidiasis. There can be underlying dysplasia sometimes in hyperplastic candidiasis, so we have to kind of, exclude that there may not be some underlying dysplastic lesion in this patient as well. Sometimes we ask the clinicians to treat the candidiasis and then rebiopsy if dysplasia is still a concern. Additional infectious diseases of the oral cavity and larynx include squamous papillomas. So these are related to low-risk HPV virotypes 6 and 11, which is in contrast to squamous cell carcinomas, which we're going to talk about subsequently, which are the high-risk virus types. These are often single lesions. Here's an example of quite a large one on the palate. But remember that in patients who've acquired HPV through the birth canal of their mothers, as being born, these patients can develop recurrent respiratory papillomatosis throughout the tracheobronchial tree and lungs, and these can be very difficult to treat. This is an example of a single squamous papilloma with a fibrovascular core lined by thick squamous epithelium. The characteristic nuclear features of HPV include coilocyte change, meaning sort of wrinkling or racinoid nuclei, binucleation, and perinuclear halos or perinuclear clearing due to glycogen content in the cell. So just as a reminder, these leukoplakic white, erythroplakic red, or leukoerythroplakic lesions of oral mucosa, we've seen some various examples of what they might be, including autoimmune, infectious, but of course, one thing to always consider is that these may represent dysplasias or carcinomas. And so biopsy is going to be critical for diagnosis of those. So here's an example of things you might see in pre-dysplastic or dysplastic epithelium. So hyperkeratosis is an early finding that is, just a thickened keratin layer at the top of the epithelium, as I'm pointing out here. Of course, we always want to look at the epithelium underneath the keratin layer to determine if there might be any sort of dysplasia. My cat's going to walk right in front of my computer right now. So in the epithelial layers, we want to look for nuclear enlargement, hyperchromasia, mitotic figures, loss of polarity or disorganization of this basal layer, as seen here in mild dysplasia. When we grade the dysplasia of the oral cavity, we eliminate the superficial keratotic layer. So when I'm grading, for example, I'm only grading from here to here. And as you can see, the basal layer is quite expanded to occupy about 2/3 of this epithelium. So this we might call moderate dysplasia. And finally, on the bottom right, if you were to flip this from top to bottom, you essentially couldn't tell what's top and what's bottom. All of the cells are very enlarged, very hyperchromatic, except of course, eliminating this very superficial keratin layer. So this would be severe dysplasia, which is often considered to be synonymous with squamous carcinoma in situ. So as an overview, for keratinizing dysplasias, the usual etiologic factors are, of course, things like tobacco, alcohol, and in relative geographic areas, betel nut chewing. The problem with squamous dysplasias of the oral cavity is that sometimes you can get invasive carcinoma arising from a mild dysplasia, sometimes from a moderate, sometimes from a severe, sometimes even from hyperplasia without dysplasia. And so diagnosis and treatment of oral squamous cell carcinomas can be challenging because if we, think back to medical school, think about cervical model of dysplasia with pap smears, et cetera, pap smears work because the cervical squamous epithelium goes from, mild dysplasia to moderate to severe to invasive. The oral cavity doesn't do that. It can jump around and it doesn't have to progress through that direct sequence. So just remember the field effect of alcohol, of tobacco, et cetera, makes this a very challenging disease to treat. Here's an example of the histology of invasive keratinizing squamous cell carcinoma, with these irregular infiltrative islands of squamous cells, sometimes with keratin pearls is kind of the buzzword for these types of structures. We frequently see perineural invasions seen here on the bottom left. So people can, of course, have nerve pain. These can track up the cranial nerves and be difficult to resect. So moving into the non-keratinizing carcinomas of the head and neck, these are carcinomas that occur in the lymphoid-rich areas of Waldeier's ring. So hopefully you may remember what Waldeier's ring is. It's essentially the inflammatory lymphoid-rich kind of areas of the pharynx. So starting at the base of tongue, we have the lingual tonsil, right? Moving up on either side, we have the palatine tonsils. At the very, very top in the nasopharynx, we have the adenoids, and then there's also thought to be smaller tubal tonsils by your eustachian tubes. So this is Waldeier's ring. This is your protective, inflammatory rich area. However, carcinomas can develop in these sites, and they're morphologically and etiologically somewhat specific in the, particularly because of their association with viruses and their tendency to be morphologically non-keratinizing. So I'm going to talk about oropharyngeal and nasopharyngeal non-keratinizing carcinomas together because I think they're good mirrors of each other. So the oropharyngeal cancers, we're talking about the base of tongue and the palatine tonsil, and the nasopharyngeal carcinomas, we're sort of talking about those arising in the pharyngeal tonsil or the adenoids. Oropharyngeal carcinomas tend to be associated with HPV, human papillomavirus, nasopharyngeal, of course, EBV, Epstein-Barr virus. Both are very blue, so-called basaloid, non-keratinizing, meaning, yes, they probably have some amount of cytoplasmic keratin because they're still squamous cell carcinomas, but the amount is so minimal that it can be very hard to see on H&E stains. And they arise in a background of lymphoid stroma because of the tonsillar rich tissue in which they arise. Why do we care about these viruses is probably because of their prognostic import. So specifically HPV associated oropharyngeal squamous cell carcinomas have an excellent prognosis compared to non-HPV associated carcinomas. And so as you all know, here at the U of C, we have clinical trials for HPV patients that will receive essentially de-intensified therapy. So the point is to target the cancer as much as possible, but reduce the burden, right, on the surrounding normal tissues. Because these are so chemoradiosensitive, they require less chemo, less radiation, right, than your classic non-HPV associated. Similarly with EBV in the nasopharynx, these are thought to have a somewhat better prognosis than the non-EBV related, but we don't really have any, as far as I know, no de-intensified therapy for these patients. What we can do though is monitor the serum EBV titers for disease, residua, recurrence, etc. Here's an example of your non-keratinizing squamous cell carcinoma of the oropharynx. Remember, here on the left is a very little bit of kind of normal squamous epithelium. And then throughout the majority of this section, you have expansion by this very, very, very blue tumor. You can see at the base here are these other smaller bluer cells, right, which are your lymphoid stroma. And you can see very clearly on P16 immunostain an intense, strong brown reaction. So the P16 immunostain is a surrogate marker of high-risk HPV involvement. So the high-risk virotypes we're talking about are usually 16, 18, 31, 33, 45, 50s, et cetera, et cetera. There's a lot, but the most common one we're dealing with is viral type 16. These patients tend to be middle-aged men who present with cystic lymph node metastases, right? So any enlarged neck lymph node in a man of this age group should really be considered carcinoma until proven otherwise. Here's a higher power histologic example. You may say, where's the tumor? Well, it can be very hard to identify because the background lymphoid stroma is blue and the tumor is very blue, right? So in this case, you may or may not see any surface dysplasia, but you will see these deeper, very blue nests that are considered to be broad-based invasion by tumor. So this entire nest as I'm highlighting here, is all invasive squamous cell carcinoma. This on the top right here is essentially normal squamous epithelium, and this here is your lymphoid stroma. On higher power, you can see that the tumor cells have a very high nucleus to cytoplasmic ratio. There's a mitotic figure there, a mitotic figure there, but be careful to distinguish the tumor cells which have a slightly larger, more irregular wrinkled nuclei compared to the inflammatory cells down here at the bottom, which have more round, regular nuclei. But as you can see, it can be very challenging. Therefore, we sometimes use immunostains, or in this case, P16 to help us identify tumor. So P16 is a cell cycle protein that is upregulated by the HPV viral proteins that are transcribed by the host genome. So E6 and E7, I'll talk about E6 and E7 a little bit more in a second, but P16 is an extremely good marker for HPV in the oropharynx, meaning the base of tongue and tonsils, where if it shows diffuse, strong nuclear and cytoplasmic staining in the vast majority of cells, it is a highly predictive of HPV involvement. If you use P16 outside the oropharynx, for example, in the anterior tongue, in the buccal mucosa, in the larynx, this is very not trustworthy. So if you have a negative P16, that can very much tell you that it's not HPV associated. But if you have a positive or a weak or a patchy P16 outside the oropharynx, don't trust that to mean that there's virus. So confirmatory testing such as in situ hybridization or PCR for HPV DNA should be used to confirm if clinically indicated. So if you think about it, the prevalence of HPV associated carcinomas is highest in the oropharynx, right? So base of tongue and tonsil. The response to treatment is so good. The prognosis is so good. These are the patients that are undergoing the clinical trials. In the oral cavity and larynx, the prevalence of HPV-associated carcinomas is extremely low, and the clinical significance is not as clear. We don't know whether these respond as well to treatment. We don't know whether these should undergo clinical trials for de-intensified therapy. So essentially, whether something is P16 or not, whether something is HPV or not outside the oropharynx, I would argue may not have as much clinical import yet as if it's in the oropharynx. So just sometimes patients want to know, oh, is it HPV? Is it HPV? Well, unless it's in the oropharynx, it kind of may be meaningless. Does anybody have questions on HPV in that regard? Okay, so back to the mechanism of action of HPV. So the two main viral proteins that get produced are E6 and E7. So HPV is a ring. What happens is it opens and integrates linearly into the human host genome of the cells it infects, right? The host transcription machinery transcribes and translates the HPV DNA into E6 and E7 protein. E6 specifically targets P53 and E7 specifically targets retinoblastoma. So remember, P53 is your guardian of the genome. Once you remove function of P53, you don't activate apoptosis in the setting of DNA damage. You preserve abnormal DNA, therefore leading to carcinogenesis. Retinoblastoma, right, is your cell cycle regulator. And so you inactivate retinoblastoma and you can just blow through the cell cycle without regard for any problems or errors in your cell, right? So you've knocked out the two most important tumor suppressor proteins in the cell with HPV, which is why it's so highly, highly, highly oncogenic. Okay. The College of American Pathologists and the ASCO, American Society of Clinical Oncology, have come up with recommendations for HPV testing. So both of them have basically said you should perform high-risk HPV testing at least by P16 on all oropharyngeal squamous cell carcinomas. You should not perform high-risk HPV testing on non-oropharyngeal primaries, like we mentioned already. And for pathologists, we are advocating to not provide a tumor grade or differentiation status for HPV positive oropharyngeal carcinomas. Why? So if we think about the morphology, they're very blue, right? They have little keratin. So that means they're very poorly differentiated because they don't resemble squamous epithelium very much. But their behavior is not of a poorly differentiated tumor. Their behavior is actually quite good, right? So this is the one case where the grade, the histologic grade, doesn't necessarily correlate with the behavior. So these are very good behaving tumors, even though they are so-called poorly differentiated. Therefore, we no longer grade them because it's not reflective of their actual biologic behavior. We just call them HPV-associated, non-keratinizing squamous cell carcinomas. Again, the ASCO said basically the same thing. In case you want to review these papers, here's the citations for you. Just as a reminder, right, we've talked a lot about HPV, but don't ever forget EBV in the nasopharynx. So when we call something nasopharyngeal carcinoma, this basically means squamous cell carcinoma of the nasopharynx. There's no particular different morphology. It's just location. So those that are related to EBV infection, again, tend to be very blue, right? Very non-keratinizing. In the bottom left, we see EBER in situ hybridization, which detects the Epstein-Barr virus RNA. Interestingly, some cases that are negative for EBV actually harbor HPV, and some cases that are negative for EBV and negative for HPV just don't have any virus and are just generic run-of-the-mill squamous cell carcinomas. So just keep that in mind. There is a hierarchy of testing, right? So in the nasopharynx, we'll do EBV, then HPV, then maybe just generic molecular testing. In the oropharynx, we'll certainly start with HPV. Okay, any questions on squamous cell carcinomas in that regard? In the last few minutes here, maybe we'll talk about the larynx. So we're kind of moving down from the oral cavity into the larynx. There are a few both benign and malignant diseases that we will talk about. Just anatomically remember that as you move into the larynx from the epiglottis, you're going to be dealing first with the false vocal cord, the ventricle, which separates the false and the true vocal cord, and then moving down into your sort of deeper trachea. As we move kind of forward through the larynx, we're looking at our thyroid cartilages and then our strap muscles here in the anterior neck. This is just a histologic section of a larynx through that plane. Clinically, one of the more common lesions we see in the vocal cords are vocal cord polyps or Singer's nodes, or some kind of benign lesion related to vocal trauma, right? So singers, teachers, people who use their vocal cords a lot develop these nodules. And regardless of the clinical manifestations, histologically, they tend to be very similar, with kind of vascular ectasia, with deposition of this eosinophilic stromal material, with some atypical stromal spindle cells. This is in contrast to true vocal cord cysts, which are truly lined by actual, usually respiratory or squamous type of epithelium. So vocal cord polyp versus vocal cord cyst. Here's an example of your squamous cell carcinoma of the larynx. Here's your false cord, here's your ventricle, here's your true cord. In this case, you have a little lesion on the false as well as a lesion on the true. These, just like your tobacco and alcohol related carcinomas of the oral cavity, these tend to be keratinizing carcinomas with, infiltrative islands, keratin pearls, etc. So we won't talk too much about squamous carcinoma of the larynx. We will mention a cartilaginous neoplasm of the larynx, i.e. chondrosarcoma. So mesenchymal neoplasms of the larynx are extremely rare. However, if you are going to have a mesenchymal neoplasm, it's probably going to be a chondrosarcoma. This tends to occur on the cricoid cartilage and can in fact protrude into the lumen of the larynx, such that the lumen is narrowed and the patient has stridor, difficulty breathing, etc. So here is normal cartilage on the bottom and the chondrosarcoma kind of sitting right on top of it. Chondrosarcoma is graded mostly according to its cellularity level. So in this case, on the left would be grade 1, grade 2 on the right. We don't have an example of grade 3, but that would be increasingly more cellular. The most common neuroendocrine tumors that occur in the larynx are either ranging anywhere from carcinoid to atypical carcinoid to neuroendocrine carcinoma. So you may be more familiar with these tumors, for example, in the lungs, but the exact similar morphology tumors can occur in the larynx because it's all connected, right? So tracheobronchial tree up to the larynx. The most common that we end up seeing in the larynx is actually the intermediate grade neuroendocrine tumor, or so-called atypical carcinoid. These can locally recur. These can certainly metastasize to lymph nodes, but they don't really respond very well to any kind of extrinsic therapy. So primary treatment is surgical resection. All neuroendocrine tumors tend to have nested growth, tend to have nuclei with these so-called salt and pepper nuclei, meaning dark and light spots, tend to have scattered mitoses, and they are graded according to the presence and number of mitoses, as well as necrosis, the presence of nucleoli, the presence of nuclear pleomorphism, into low, intermediate, and high grade. All right, so 950, there's quite a few tumors in the nose. So I probably won't get through them in the next 10 minutes. So if it's okay with you, maybe we'll pause here and pick up with the nose and sinuses on the next visit. Does anybody have any additional questions or comments? All right, so I guess if it's okay with you, we'll end a little bit early, and on the next visit, we'll pick up in the nasal cavity.
Thanks. Thanks a lot.
Thank you.
Yeah.